Hi everyone, thank you very much for joining us for the first session of Advanced Ultrasound Teaching for 2020. It's a real pleasure here to have Payam with us, who's one of our ED staff specialists here at Nepean, who's going to be teaching us about biliary ultrasound this week. So thank you very, very much, Payam. Really looking forward to this one. Take it away, it's all yours.
No worries at all, pleasure to be in service. As Sam said, I'm one of the emergency staff specialists at Concord Hospital. I'm working as the ultrasound fellow at Nepean, working towards my DDU in emergency DDU. I have looked into the syllabus for the ICU DDU to tailor the content towards what would be possibly relevant. As far as I noticed, it's mainly the gallbladder and biliary tract assessment, not much of a hepatic assessment. So I just pretty much deleted the slides about the different, say, differential diagnosis for hyperecho, hypoecho lesions of the liver and that sort of thing. I made it more about the gallbladder and the biliary tract.
That's great. That's what the main thing and the focus of the DDU syllabus is. Yep.
Yeah. So just to make sure I'm actually keeping the copyright as well, most of the slides that I'm using is actually the VJ slides. So VJ Manuel is the DDU emergency FaceTime at Nepean Hospital, and he's my coach through the DDU preparation for the emergency part. So he kindly agreed that I use most of his slides, and I've done some changes and added and deleted some to prepare these. Now, in our exam, a lot of questions are like, explain your scan technique, which expects us to talk through the patient position for resetting, that sort of thing. So I prepared a few slides very briefly on a refresher on the anatomy, and then scan technique, and then getting into some normal anatomy and normal image findings and some pathologies. And at the end, there are 10 slides which are mostly pathologies, that I might keep it as a discussion. Each of you guys get to describe what you see and the pathology, and how you would describe it in the exam situation in the Viva exam, if they include these sort of images in the Viva exam. So just a refresher on the anatomy. Obviously, the liver and the stomach and the spleen, and we've got the gallbladder behind the rib space and behind the liver, and that being behind the rib space makes it difficult to visualize in the supine position. And we've got the splenic vein running behind the pancreas, joining the superior mesenteric vein, making the portal vein. And we've got the gallbladder with its cystic duct joining the common hepatic duct, making the CBD, common bile duct. Now, with the sonographic techniques, obviously we just start with the sagittal and transverse probe position. Patient can be well, usually it's very important to examine the patient in at least two positions, and I explain why. The first position is usually either supine or left lateral decubitus, that I explained the advantages and disadvantages of each. And the second position is something like erect or sitting, or I've seen the radiologist at Nepean radiology department doing actually the kneeling position on the elbows and the knees, so that the patient is actually prone, but they can put the probe under the patient. And I explain again why it's important. It may or may not be doable in the ICU type patients, but as long as if some of them can do that, we do that, then that would be ideal. And I explain why. So usually the way we get the image, we start with the patient, well, supine or lateral decubitus with the ultrasound probe, usually we use the curve probe for better penetration and depth. Usually the gallbladder is in the mid-clavicular line, and if we rotate the probe a little bit counterclockwise so that the marker is towards the right shoulder, it's usually aligned with the long axis of the gallbladder, but obviously different people have different anatomy, so you might need to rotate it a bit. And with a swap from midline towards the right side, we should be able to get a glance of the gallbladder, and then depending on what we can see, then we can adjust the probe position to get a better picture. Now, supine versus left lateral versus erect. Technically, with the left lateral decubitus, the gallbladder gets, we can move the gallbladder away from the ribs so we can get a better view of it. And we can actually then move the bowel content away from the gallbladder so it doesn't obscure the view of the gallbladder. And that's the main advantages of the left decubitus in comparison to complete supine. Usually it's very hard to get the view of the gallbladder in complete supine. Now, this would be what we would see in the long view of the gallbladder. So, thin wall, and usually the diameter is less than 4 centimeters. And in the long axis, it's important to get the neck of the gallbladder in the view. The reason being is that when the patient is supine or the just mildly left lateral decubitus, there might be a stone actually the neck of the gallbladder would be the dependent part of the gallbladder, so there might be a stone just in that area. And if you can see, there are a lot of hyperecho area, which would be mainly the duodenal gas. So it's very, very easy to miss a stone which is in the neck. So it's important to, and that's the importance of then turning the patient into either erect or sitting position, or that prone position, kneeling on the hands and the knees, so that we change the dependent part of the gallbladder into its fundus, so the stone falls into the fundus and we can see it, if it's not already stuck in the gallbladder neck. For the CBD, usually what we see is this two tubes parallel to each other. The bottom one would be the portal vein, and the top one would be the CBD. The hallmark of the CBD is that it's very hyperecho walls, which makes it very similar to artery. So when you look at it, it looks like an artery, but it's a CBD. And that's actually the pitfall in finding the CBD, because looking at the anatomy of the area again, you can see when we are aligning the portal vein with another tube on top of it, it can easily be the artery instead of the CBD. So if you are a little bit towards the medial, instead of having the CBD on top of the portal vein, you can have the hepatic artery on top of the portal vein. And the only way to differentiate them is to put a color Doppler on and decrease the scale and increase the gain to the point that we can easily see the flow in the portal vein. The logic is that obviously if the setting is in a way that we can see the flow in the portal vein, we would have seen some flow in the other tube, either artery, if it is artery. So if we can see the flow in the portal vein, and there is no flow in the other vessel, that has to be the CBD. If it was artery, we would definitely see the flow in the artery, because obviously the flow in the artery is much more than the flow in the CBD.
Sorry, Payam, can I interrupt you there?
Sure.
Can you please go to your previous slide, the CBD one?
This one?
No, one more.
This one?
Yeah. So if you don't mind, can you please explain what other structures you can see in these? Okay.
So this is a glimpse of the gallbladder. So we are cutting the gallbladder short, okay, as in just cutting it not a proper axis. And you can see the hepatic veins in it. You can see the CBD there. This vessel there most likely is the IVC. Technically, very unlikely it can be the aorta, but if you put the color Doppler on, depending on the color Doppler pattern, most likely it's the IVC.
Sure, thanks.
No worries. And this is just an edge shadow of the side of the portal vein. So there are some normal variations to what you might see in the gallbladder. One interesting thing is the folds that can happen in the gallbladder. Not always it's just a straightforward sac-like thing. It can get folded, and depending on how you are cutting that fold, it might look like this, which would be very similar to septations. One special form of it that I say what's the importance of it, they call it a Phrygian cap because of that resemblance to a Phrygian cap with the vent at the top of it.
Sorry, what do you call it? Is it
Phrygian cap?
Say again?
Phrygian
cap. Thank you very much.
No worries. It's written there and it's a Phrygian.
Yeah, my Greek's just bad. I just wasn't sure how you meant to say it. That was all. Just check. Phrygian.
Okay. The other normal variant, you remember I said the gallbladder wall is supposed to be thin, less than 3 millimeters. Sometimes you might think that it's thickened, and in the right context, for example, somebody with fever, right upper quadrant tenderness, people might think it's thickness of the gallbladder because of the cholecystitis. But actually, in a very contracted gallbladder, so somebody who just had a meal, it can look a bit thick walled like this. We go through the differential of the thick gallbladder wall later on. So that's another normal variant. Then some large gallbladder wall. If it is more than 4 centimeters, usually we need to think about possible pathologies. But in some not very acute, acute problems, it can be large as well. For example, in a patient who is fasting for a long time, atonia of the gallbladder, advanced age or height groups, or empyema of the gallbladder, it can still be very large. So some of them acutely pathologic, some of them not acutely pathologic. So, for example, this can be a easy written question. We get these sort of questions as part of a question usually. Usually it's a multi-part question. One part of it might be outline the differential diagnosis of a large gallbladder, or outline the differential diagnosis for a thickened gallbladder wall. It's not always just a cholecystitis. So it might be a question. Usually our questions for the written exam has 15 points each. For example, it might be 3 parts. One part of it be differential diagnosis for large gallbladder, expecting 5 points on that, and say the other part be differential diagnosis for thickened gallbladder wall, that sort of thing. Now, with the Cholelithiasis, the stone, so as you can see in the image here, you can see the hyperecho area followed by a shadow. The important thing is that you can see this shadow only if the size of the stone is more than the beam width at that area. So it's very important when we think that there might be a shadow, there might be a stone somewhere, put the focus there to minimize the beam widths in that area. Even then, obviously any stone less than 2 or 3 millimeters, depending on the quality of your ultrasound probe, how wide is the beam width at the focus, you might miss it because you might see the hyperecho area, but you might miss the shadow. It might not cause a shadow. For example, if you are searching actively for a possible stone in the gallbladder wall with all of those hyperecho areas around it, and we don't know whether they are bowel gas or the stone, one technique is you can put the focus on the gallbladder neck to make sure that if there is a shadow, you would see the shadow of the big stone at least. Now, this is an example of a stone in the gallbladder neck, and you can see the big shadow after it. And these are multiple small stones. So it's just mainly a mix of small stones and probably sludge in between. Now, one thing that again is a quite common question.
Hey, I'm sorry. If
yeah.
you go back to the previous slide,
Yeah.
where is the stone on the left image?
This one? So this is the stone, the hyperecho roundish convex thing.
Oh, okay.
And the rest of it, the shadow after. And this is an important thing. I talk about it in more details in the slides that are coming. The shadow of it, as you can see, is a clean shadow because we have two kinds of shadows in the abdominal exam, the dirty shadow and the clean shadow. So the clean shadow is when you technically don't see anything after it, okay? And you can see here, you can see a clean shadow as well. You don't see anything inside it. It's just a complete, almost anechoic area or very hypoecho area. And that's how you differentiate the bowel gas from the stone. And I have better images of those things, which you can see. It can be very similar and it can actually cause mistakes. And it's commonly mistaken, the bowel gas with the stone. But before we get to that, this is another common question. You will see this image and you can see, for example, this would be the liver. And this might be an obvious one, but in less obvious ones, you might think this is a contracted gallbladder and that being the bowel gas after it. But actually, this is a very, very huge stone, pretty much completely obstructing, filling out the whole gallbladder. The way to differentiate is the sign called VES, wall echo shadow. So this is the gallbladder wall. And then you can see the echo, and you can easily see the differentiation between the gallbladder and the stone. And then you can see the echogenicity of the stone and then the shadow after it. Because right after this, there's another pathology in the gallbladder called porcelain gallbladder. Again, I don't know how much of this detail you are going to get into in the ICDD exam, but for example, this is a very common question for us, differentiating between the porcelain gallbladder and a big stone. So porcelain gallbladder is when you get a calcification in the gallbladder wall. The importance of it is that it predisposes the patient to the gallbladder cancer. And the way you can differentiate it from a big, huge stone in the gallbladder is that VES sign that you can see in the gallbladder stone. The wall, the easily differentiable, pretty much gallbladder content and the echogenicity of the stone. So you can see the wall and the echogenicity of the stone quite separate, and then the shadow after it. And usually, because it's a complete cast of shadow, you don't see anything after it. But in the porcelain gallbladder, which is just a calcification of the gallbladder wall, you don't see that easily differentiable gallbladder wall and the echogenicity of the stone. It's just one echogenic area. And another important thing is that usually with the gallbladder, the porcelain gallbladder, because it's not a full shadow after it, there's still a bit of a ultrasound waves passing through that calcified gallbladder. You can see the posterior wall of the gallbladder through that shadow. So it's not a complete shadow. You can still see the posterior wall. So that's the porcelain, and that's another example of the porcelain gallbladder. You can see the calcification of the gallbladder, and you can see that it doesn't cast a complete shadow. You can still see the posterior wall. If that calcification is thick enough, technically it can cause enough shadow to actually obscure the posterior wall. But the difference is still there because you cannot see that VES appearance of a big stone. You cannot see that wall echo shadow sort of trial. There are some mimics to the stone, the most common of which is the bowel gas. This one is a bit more obvious, but I can find images that a lot of people would say it's a stone, but it's actually not. When the echogenic area is too close to the wall, which actually fuses with the echogenicity of the wall, it really looks like a stone in the gallbladder. And the difference is the type of the shadow they actually create. If you can see in the stone sort of example, it's a clean shadow. And in the case of the bowel gas, it's a dirty shadow because the gas causes some sort of ring down reverberation artifact that stone doesn't, and that looks like something like the B lines that we can see in the lung exam. Same sort of appearance. So bowel gas causes the dirty shadow, and the stone causes the clean shadow. That's another question that comes quite often in the exam, to mention that pitfalls of the, say, gallstones, and that's one of them, and how to differentiate it and how to recognize that it's not a stone. The other one is the stone which is stuck in the gallbladder neck. As you can see, it can be easily missed and interpreted as pretty much some echogenicity of the rest of the bowel that you can see in that area. In that area of the gallbladder neck, you can see a lot of echogenicity, and the stone there can be easily missed. The only way to find it is try several things, like putting that focus zone there and increasing the depth, trying to see the clean shadow after it. Or if it's not stuck there, you would see it fall down to the fundus when you change the position of the patient. For example, a very common question for us is to outline the pitfalls to find a gallstone, which would be all of these things, and how to differentiate them, that we can actually mention as the bullet points at the top of each subsection. When you mention the whole pitfalls and how to differentiate them, totally it would be about, say, 15 points of a written question. The other pitfall is that Phrygian cap that we mentioned earlier. So if you don't consider the possibility of a folded gallbladder creating a Phrygian cap, you might think this is the gallbladder fundus ending there, and this being just a bowel gas outside of the gallbladder. But again, the way to differentiate them is that clean shadow coming after it, and if you fan the probe, you can actually see the connection between that Phrygian cap and the rest of the gallbladder wall. Mixing these two, seeing that connection, and then seeing that clean shadow after that can help identify the system. This is an example of that stone which was in the gallbladder neck, and we couldn't see it in the supine position. But when we put the patient in, and by lateral decubitus, to be able to make the fundus the dependent part, you can imagine it's not just a little bit of lateral decubitus, it would be either sitting up the patient, or if you want to get the patient lateral, it would be total lateral. So technically the patient is even not 90 degrees, it would be a bit more than that to get the fundus into the dependent part, so that the stone actually falls into the fundus, and then you can easily see it. Otherwise it would have been missed. You couldn't see it in the supine position at all. The other thing is sludge. A lot of people with the cholecystitis actually don't have any stone. They might actually just have a sludge. You can see it as a hyperecho area. Usually it doesn't cast any shadow. Sometimes if it is dense enough, it can cast a shadow. A very common thing to mistake with it is, for example, just artifacts in the reverberation artifacts or side lobe artifacts with the ultrasound can look like a sludge, but that clear gravity level, which can actually change with the change of the position, would be a giveaway that this is just a sludge. Some subtypes of the sludge can be a sludge ball, so it can actually accumulate and become a bit denser and look like a ball, which can actually resemble a lot to some kinds of polyps. We see polyps later on. Big polyps can actually look like that. Obviously, if you put a Doppler on, the polyp usually has flow in it, but the sludge wouldn't have any flow in it. And if it is a gallbladder full of sludge, it can be actually a hepatization of the gallbladder. This one is a bit easier to identify, but if it was a smaller gallbladder hepatized, it's very easy to miss as a gallbladder totally. So some other pathologies, acute cholecystitis. So there are some features to acute cholecystitis. No single of them actually are diagnostic for cholecystitis. Each of them adds some sort of probability to the diagnosis of cholecystitis. So the positive Morphy sign, for example, when you are pushing on the gallbladder with your ultrasound probe and the patient reacts like the examination Morphy sign, that's one indicator. Fluid around the gallbladder, persistent polycystic fluid, that's another thing. Thickening of the gallbladder wall, more than 3 millimeters is another thing, and stone stuck in the gallbladder wall, in the gallbladder neck. Now, there are some studies showing that some positive predictive value and negative predictive value to the combination of these. I really doubt they would get into these sort of details with your exam, but the information there is if you want, mixing different sort of findings and how would be the positive and negative predictive values with these. Generally speaking, if there's no stone and the patient doesn't have any tenderness over the gallbladder, it's a very good sign that makes it extremely unlikely for the patient to have cholecystitis. Having said that, there is an entity called Acalculus Cholecystitis. So there's no gallstones, but you can still have cholecystitis with the whole features of gallbladder wall thickening and pericholecystic fluid that you can see a little bit of that there. And most likely tenderness with the Morphy sign positively. Now, again, the another question that we get very commonly is, for example, different causes for the thickening of the gallbladder, because it's very common to see, well, a lot of people have stones in the gallbladder normally. And if you see a gallbladder with a stone in it and a thickened gallbladder wall, it's very easy to jump to the conclusion that it's a cholecystitis. But in reality, there are many, many differential causes for the cholecystitis. Just because we are running out of time, to be honest, I skip on that, but this slide is available if you think that it might be a question for you guys. This is, for example, something that we have to know by in very details, and we should be able to reproduce the differential diagnosis. It's a very common question, for example, for us.
I think this would be absolutely a classic question that would be asked in the exam, and it would be yeah, great to have be able to have a copy of some of this. It'd be great.
Okay. Complications of acute cholecystitis, it can cause empyema, gangrene of the cholecystitis, emphysematous cholecystitis, and hemorrhagic and gallbladder perfusion. Again, just to save some time, I deleted some of the images of some of them, but I have included the other ones. So you can see here, there's a gallbladder wall with there's a gallbladder with a thickened gallbladder wall, sloughing of the gallbladder mucosa, and some membranes inside the lumen and here as well. So that can be the features of the gangrenous cholecystitis. Again, for example, this sort of question can come up in Viva a lot. For example, they might put up this kind of question and then say, describe what you can see. They would have some stem on it, as in, say, this many year old patient coming with right upper quadrant pain and tenderness. What do you see? What sort of further images do you want? And what would be the differential diagnosis for it? Interestingly, morphine would be negative in about 70% of these kind of cases, which can be a very, very misleading feature in both examination and ultrasound examination. You put your hand on the patient, you see morphine is negative, it's very tempting to say nothing's wrong with the gallbladder, but not really. You can see gallbladder there with echogenic area, but that echogenic area interestingly casts dirty shadow. It's definitely in the gallbladder, but it's casting dirty shadow. Same as here, you can see echogenic area coming in pretty much carefully the level sort of pattern, horizontal patterns with dirty shadow. And the first thing that comes to mind is pretty much, well, it's not that obvious, but that dirty shadow within the gallbladder is not that very common. It's actually gas in the gallbladder, suggestive of an emphysematous cholecystitis. Again, this is a quite common question for us. Okay. I don't know whether I should get into this. Sam, what do you think? Adenomyosis of the gallbladder, so different lesions in the gallbladder, like this sort of thing. Have you seen this sort of questions in your exam?
I think this might be stretching a little beyond where we've got to go. We've got about another 20 minutes.
Well, I might ask this, and just one thing that I think probably you would need to know, the polyps, as you can see, that they are very hyper-echo things, usually round, usually small. They usually don't cast a shadow. They are very common and very commonly mistaken with the gallstones. There is a path, well, there's no common consensus on how to deal with the polyps, but we could find this kind of pathway which makes kind of a sense. Again, I don't know whether this would be the sort of a question that they might ask you how to deal with a polyp. But technically, I would imagine if you see a polyp, it wouldn't be a cause for any sort of ICU admitted patient. So I assume logically they wouldn't expect you to know that sort of thing. You would just ask for the gastroenterology.
Surely it'd be important to know in a differential for a mass in the gallbladder, how you differentiate that from a stone, because I guess we go looking at everything from cause of fever, from Acalculus Cholecystitis through to gallstones. If you see these, we should be able to differentiate this from pathology that we might see, right? So I think it's worth knowing about.
Yeah, so with the polyps, there are another thing. So if you can imagine, they are usually in the middle of the gallbladder. So that if it is a stone, usually when you change the position, you can see all of those stones just move and just go into the dependent area. So when the patient is supine, you can see them lying pretty much there, like that image that we had earlier. And when you put the patient in the erect position or the left lateral, too much left lateral, to make the fundus as the dependent part, they all move towards the fundus. Having said that, sometimes the stones are stuck to the gallbladder, which make them very difficult to differentiate between them and a polyp. The other thing with the polyp is a perfused tissue. So especially if they are big enough, if you put color Doppler on it, decrease your scale to the minimum and increase your gain, you should be able to see some flow in it, but obviously there wouldn't be any flow in the stone. And if there is a stone this big, unless if it is a sludge ball, small sludge ball. Sludge balls don't cast a shadow, but a stone this big, it would be extremely unlikely that it doesn't cast a shadow. You should be, if you put your focus in that area, it should cast a shadow. But none of these are 100% thing. The best thing would be that movement of the stone with the position. Rest of them can be seen in both polyp and the stone, to be honest. The other thing that is important to know is the intrahepatic duct dilation. For example, in the patient with fever, right, sort of upper quadrant pain and tenderness, probably a bit of a raised biliary cholangitis. Knowing how to look for the intrahepatic duct dilation is important. Generally speaking, the biliary tree and the portal system branch together. Usually, biliary tree after the CBD are so small you barely can see them. You can just see the branching of the portal system. But in the intrahepatic duct dilation, you can see the double. There are several names for it. The most common thing is double barrel or the rail traction. That you can see the two big tubes parallel to each other. And for example, in this one, because we have found this way, we can see these two to each other. But if you fan the other way around, we can see the double tracks coming alongside the other ones as well. And that's a sign of intrahepatic duct dilation. For example, this one was caused by stones stuck in the CBD. Common pitfalls. Just mistaking the duodenal gas with mistaking between the duodenal gas stones, polyps, sludge balls, which can be very hard to differentiate. Misinterpreting the gallbladder wall with the thickened gallbladder wall in a contracted gallbladder. For example, a patient who just had something to eat postprandial with the cholecystitis. And if there is a gallbladder wall completely filled with a sludge, if you cannot see the wall of the gallbladder, you might actually think that there's no gallbladder at all. And I'll just pass on quickly to images. So I've got 10 slides, probably we've got 10 minutes, 1 minute each. Do you want to start with, Luis, do you want to start?
Okay. This might be cheating because it looks very similar to the picture that you showed of the sludge ball. But this is the gallbladder, it's longitudinal, that's towards the fundus. There's no acoustic shadowing, it appears to be homogeneous. I'd like to see this with the patient in a different angle and with the scan taken at a different angle to clarify, but it looks either like a sludge ball or possibly a polyp.
Yep. And if you're thinking about possible polyp and we cannot move the patient to see that it's moving, what can we do?
If we can't move the patient, put color Doppler with the small gate, low velocity detection to look for blood flow in a polyp and none in the sludge.
Perfect. And with that color Doppler, obviously, we would need to reduce our scale and increase the gain to see a small field. Perfect. Now the next one, Vishal, do you want to comment on this?
Sure. So it's again gallbladder in the longitudinal view, and the gallbladder wall looks a little bit thickened to me, but probably I think I would like to see in different 2-3 angles. Mm-hmm. And at the neck of the gallbladder, there is a hyperechoic density, but I can't see any acoustic shadowing related to that. But proximal to that, there's acoustic shadowing, which is a clean shadow. So I'm suspecting, there's a stone over there. But just, next to that, looks like there's hyperechoic, area which may be related to the duodenum in this area.
Yeah.
So I'm suspecting there's a stone near the gallbladder wall neck with possible slight thickening of the gallbladder wall.
So what do you think about that?
Yeah, that's what I was commenting, that just below to that there's a clean shadow going on. So, it's possible there's a stone there. So I think probably we need to do the imaging in the erect position, and we need to change the position of the patient.
Perfect. So there are two stones there. One is that with this
Yeah.
clean shadow, and one is that with this clean shadow. So this is the shadow. And that area with the dirty sort of shadow after it, both of them are just the junction of the gallbladder with the duodenal gas.
Yeah.
Regarding the thickening that you mentioned about here, that's another pitfall. If you imagine the ultrasound beam is coming from there, widening up like that, so anything pretty much not perpendicular to the ultrasound beam can be, because of the ultrasound beam width artifact, it can be actually smeared, okay? And that smearing is to the width of the ultrasound beam.
Yeah.
And usually at that sort of depth, with most ultrasound transducers, especially if your focus is not there, you're looking at 4 or 5 millimeters of the beam width, something like that, okay? So that's why we usually don't measure it there. We get a perpendicular area, for example, that area that the gallbladder wall is completely perpendicular to the ultrasound beam, and measure it so that our accuracy would be to the point of the vertical resolution of the ultrasound, which is much better than its horizontal resolution. Okay?
Yeah.
If we are concerned about that part, one thing that you can do is to again get a transverse view of the gallbladder, get the patient to breathe in, to move the gallbladder further forward, and then you can get that part pretty much perpendicular to your ultrasound beam and measure it actually in line with your ultrasound beam, which would be your vertical resolution rather than relying on your horizontal resolution.
Yeah.
Lateral resolution. Good. Now, this one, Ramsey, you want to comment on this?
All right. So I'm not entirely sure what I'm looking at, but it probably is the gallbladder, and there is the hyperechoic structure up there on the anterior wall, which again does not have a clear acoustic shadowing. There's another one on the posterior wall as well, very tiny, which could be consistent with polyps, intramural polyps. So again, looking for vascularity, we'll be doing Doppler examination with small gate, low velocity to see if there are any vessels there.
And moving the patient to see if they move.
Yeah, so move the patient and see if they're moving. If they're unlikely to be stones, but to see if they're moving it.
Excellent. And that's another example that you can see the gallbladder wall when it is perpendicular. The area that is perpendicular is actually narrow. It's less than 3 just by eye body. But in this area, because it's a bit horizontal, just cutting the ultrasound beam in a horizontal way, it's actually smeared out. So are we back to Luis? Or
we've got Danielle from Liverpool Hospital with us as well. Danielle, are you up for answering a question?
Hello. Yeah, I think so. Sorry, I got caught short, so I'm actually watching this whole thing on my phone.
Oh, that's all right.
It's a very tiny screen.
Well, are you happy to have a go and to get involved? You can pass it.
Yeah,
and
look,
introduce, by the way,
I'm happy to have a go at this. Yeah.
And obviously, this is Payam, who's one of our ED specialists who's teaching us.
Danielle. Hi, Danielle.
Yeah, thank you so much. I came in about halfway through, but yeah, it's been fantastic so far. So now, what are we looking at here? I'm trying to figure out what that linear hypodense structure is in the middle of the screen, and is that the common bile duct?
Excellent, good job.
In which case I would say it appears you'd need to measure it, obviously, but I suspect it's dilated, which if it was above 10 millimeters, I would consider that to be significant. And there are two arrow signs pointing to hyperechoic structures, which have acoustic shadowing posterior to them. And so I suspect if the bile duct is dilated, that those are potentially impacted gallstones, which would be consistent with the diagnosis of cholecystitis, with probably with cholelithiasis.
Perfect. In the exam, that was perfect. Actually, the description in the exam scenario, I think they would like to say things like, I think it's CBD and the portal vein, but I would like to put a color Doppler on to make sure that there is no.
Yeah, to make sure there's no flow within the bile duct. Yes, thank you for reminding me about that. Yeah.
And yeah, so the hyperecho, as you mentioned, with clean shadows such as silver stones, and obviously we need to measure it, but just by eyeballing it, you can say it's dilated. Now, regarding the
normal again, so the normal common bile duct diameter.
There is a bit of a range to it. So up to 6 millimeter is normal. Most people are less than 4 millimeters, but up to 6 millimeters is normal. After age of 60, you can divide age by 10. For example, if somebody is 70-year-old, 7 millimeter is fine. 80-year-old, 8 millimeter is fine. The other thing is post-cholecystectomy, up to 10 millimeter is fine.
Can I ask one more question? Because it's maybe a very basic question. So sometimes I really struggle to find the CBD. So what's your tips and trick to find the CBD?
Did you try in supine position or put the patient in the pretty much 45 degrees lateral position?
So in ICU, it's always like 30 to 40 degree, kind of thing.
To be honest, it can be very, very hard. There is a little bit of so other than changing the position, I assume most of your ICU patients cannot take a deep breath in and hold. Unless they are tube, then you can do it for them. There's not much else you can do technique-wise. It's just a matter of finding the portal vein, and usually, again, different people have different anatomy, but usually if you rotate your probe towards, say, 11 o'clock, so a little bit from complete vertical position to the 11 o'clock, usually that would be aligned with your CBD. But to be honest, if you cannot change the position of the patient, there's not much else you can do.
Sure, thanks.
So, I don't know, Luis and Sam, are you guys actually?
Yes, it's us three. We also got VJet here as well.
VJet. So, do you want to?
Let's go first.
Oh, okay. So this is a longitudinal view of the gallbladder. The wall is a little bit hyperechoic, but can't reliably measure the width because it's too horizontal. There seems to be a denser shadow at the neck of the gallbladder, but we don't see a discrete black shadow behind that. It could still represent some degree of sludging. We'd want to see it in a different angle to see if we could actually demonstrate a dark shadow behind it.
And colour.
And colour.
Because it could be a polyp, I guess. Yeah.
So, and if we put colour Doppler over it and see flow, then it's obviously a polyp.
Perfect. Now, just to make sure, because this issue of the clean shadow and dark shadow can be, dirty shadow can be a bit confusing. If you look at, for example, this dirty shadow of the gas, you can see it's actually a bit more hyperecho in comparison to surrounding area. Or let me just go back a little bit further. So what if it was? No, it was very bad. Because that was actually a clean shadow after that stone.
Oh, was it?
Yeah.
It didn't
So,
look very clean.
yeah, because it wasn't very clean because those previous ones were pretty much the perfect sort of clean shadows. It's not always that perfect.
Yeah, but if you can't, if it doesn't look that, if it doesn't look black,
yeah.
then you can't say that there's a clean shadow, can you?
It's still more hypoecho in comparison to surrounding rather than excellent. Now, you see how the shadow after these stones are actually hyperecho in comparison to the, say, this area that doesn't have any gas.
Mm-hmm.
Does that make sense?
Yeah.
I know that this is a complete anechoic area, but right after the stone, it's not always that completely anechoic. It can be like the stone that we just saw. For example, this is bowel gas, and you see this dirty shadow looks like a beeline in the lung ultrasound, and it's more hyperecho in comparison to even the surrounding area.
Yeah, I can see that. And I think that those dirty shadows, they look exactly like beelines on lung ultrasound.
Yeah, and now back to this example that we just had. I see what you mean by this shadow still having a little bit of echogenicity in it, but do you agree that it's still hypoecho in comparison to the surrounding area?
Yes.
Okay. It can be a bit hard to differentiate between them sometimes. And this, for example, might be because the focus is not exactly in that area. If it was pretty much the lowest part of the focus is in that area, but most of it is above this area, looking at the gallbladder wall, because they are focusing on that thickening of the gallbladder. And I do understand that, yes, you're right, this is the area that is not perpendicular to the ultrasound, and that's actually smeared out a little bit. But even this area, this is completely perpendicular to the line because it's a curved probe, so the line is coming like that. So even in that area that is completely perpendicular to the line of the ultrasound beam, it's still thickened. And the other thing is that, do you see that striation, that sort of heterogeneous sort of looking hypoecho, hyperecho? That's actually edema inside the gallbladder wall. So I don't know whether you guys do the soft tissue ultrasound for cellulitis. It looks like that. It looks like a couple of stoning appearance that we see in the cellulitis. That's actually edema of the gallbladder with that sort of not homogeneous hyperecho appearance of a normal gallbladder wall. It's some sort of heterogeneous striated sort of appearance. So even in that area perpendicular to the ultrasound beam, it's thickened. And you can see some hypoecho lines around it. You see that area? And maybe that.
Yeah.
That's actually persistent fluid, like that. That there.
Okay. Yep.
And look, there's a little bit of echogenicity inside it, but this shadow is still hypoecho in comparison to the around it. So it's still counted as counts as pretty much a clean shadow. So this looks like to be a stone with this clean shadow after it. So this is a case of a cholecystitis due to the stuck gallstone in the gallbladder neck. Pretty much fulfilling the whole, other than the ultrasound morphic sign that we cannot see in the image. The rest of it is there. There is gallbladder wall thickening. There is a little bit of a pericholecystic fluid and the stones stuck in the gallbladder wall. I lost your voice.
Why wouldn't your guys actually give you a measure so that you've got something to decide whether that gallbladder wall is thickened or not? So why don't you have the
Very good question.
the scale on the side? Why don't we have a scale on the side so we can actually say whether or not that's enlarged or not?
This image actually has been cropped to get the patient information out. So if we can see, actually, even the field is not complete. So this area and that area would be usually the patient information. So they have cut it off. Otherwise, usually in this either right side or left side, there is a scale of the say centimeters in this case. And ideally, you would have some calipers actually measuring it there. And there would be a good area to measure it because, as I said, it's a curved probe. So this is actually perpendicular to the direction of the ultrasound beam in that area. But this beam here is coming this way. So it's completely, well, anything away from perpendicular is maybe 45 degrees to the gallbladder wall. Does that make sense?
Yeah. Hey, Pam, I think we're sort of running out of time, unfortunately, because I think that's sort of the hour is up. But maybe if we got time maybe for one more quick one?
Yep.
We have Vijay.
So yeah, this looks like a gallbladder in the long axis, and it's contracted with the walls. Looks like it's thickened, but it could just be normal because of the construction, like post-meal. I can't see any stone or sludge around that, or there's no echoic description in the wall suggesting any edema. So I think it's normal.
Excellent. Good job. I'm just running through them. This is another cholecystitis with a gallbladder wall thickening, double tract sign of the intraductal intrahepatic duct dilation, gallbladder full of stone with this complete shadow after it, with wall echo, with the west sign, wall echo shadow sign. And this is a case of a porcelain gallbladder. And that was all.
Hey, Payam, thank you. That was absolutely fantastic. That was exactly what I guess we're after, which was a biliary ultrasound in 1 hour. That was amazing. Thank you very much, all of us.
Thank you, guys.
Thanks very much.
Thanks very much, man.
Thank you.
Thank you very much. Cheers.